All right, welcome back, everyone. I see folks are filtering in, so I'm just going to give it just a couple of seconds so folks have a moment to join. Welcome back, everybody. I think we'll go ahead and get started. So we are really excited to get our next session started with this great panel of experts. This panel will provide information on overdose prevention, which would include information from local overdose fatality review teams, as well as state-level overdose epidemiologists and folks that are experts in this space. And I'm really excited to have with us today folks from a couple of different states across our region, representing different areas of expertise and background. Our presenters are Constance Kostelac, Amy Parry, Sara Morgan, and Allie Lake. I'm going to have each of our speakers unmute in just a second and give you a quick introduction of state that they're from and their role as it relates to overdose prevention. But I do just want to mention that the full bios for our speakers can be found in the speakers tab in the event platform. And if you have any questions during today's panel, you can certainly surface those questions using the session chat on the right of your screen. And we will leave time at the end to answer those questions. You can certainly private chat presenters or panelists later as well if you would like to. So let's get kicked off with our overdose prevention panel this morning. So again, I'm just going to ask our speakers to unmute, and I'll call you off so that we're not talking over each other, to give us your name, the organization that you're with, and then the role that you play in relation to overdose prevention or research. So I'm going to start with Amy.
Hi, everybody. Amy Parry. I'm at Medical College of Wisconsin. I'm a program manager, and I work very closely with Connie, who will be introducing herself momentarily, and do quite a few things in the overdose prevention space. But one of my primary roles is to be a training and technical assistance provider to our local overdose fatality review teams that we'll tell you a little bit more about later. And then in addition to that, I help to facilitate the Milwaukee County team, which we actually call the Milwaukee Overdose Public Health and Safety Team. So glad to be with all of you today.
Thanks, Amy. Welcome. Connie.
Thanks, Sarah. Good morning, everyone. I am Connie Kostelac. I'm an assistant professor at the Medical College of Wisconsin. So as Amy said, the two of us work closely together on supporting our local overdose fatality review teams and our local overdose public health and safety team within Milwaukee County. I also am involved in a variety of other research efforts related to overdose prevention. And we're doing everything from some innovative work with causal loop diagramming to doing some qualitative work, but all centered around how can we better understand and look at ways to design interventions and prevention efforts that can hopefully save people's lives and keep people safe. So really glad to be with you all this morning.
Great. We're really glad that you're with us this morning, Connie. Sara.
Good morning, everyone. I'm Sara Mormon. I'm the Violence and Injury Prevention Section Chief here at the Ohio Department of Health. And so in Ohio, my role is mainly to oversee our prevention, drug overdose prevention, and community harm reduction efforts. I also work closely with our violence and injury epidemiology and surveillance section to make sure that we are as data-driven as we can be in our state. Thanks for having me today.
Yeah, thanks for being with us, Sara. And Allie.
Hi, everyone. My name is Allie Lake. I am the drug overdose prevention epidemiologist at the Indiana Department of Health. Shout out to Morgan. She is my connection here at MIPA and a great coworker of mine. I mainly work with data, as my title suggests, under the Overdose Data to Action grant through the CDC. I wear a couple of different hats and work with a lot of teams throughout our agency, namely our harm reduction, fatality review, and Office of Data and Analytics. But my main job is the data analysis and providing data for our programmatic areas.
Wonderful. Thanks, Allie. And actually, Allie, we're going to start with you with our questions for today. So just a couple of I guess, a two-part question. So first of all, in your work as an overdose prevention epidemiologist in Indiana, what trends have you seen in your state related to overdose since the COVID-19 pandemic? And then the second part of that question is, how are those trends different from what you saw in the time period before the pandemic?
Yeah, that's a great question, and one that we actually get quite frequently from different populations that we serve in different teams. But um, like everyone else, Indiana saw a very stark increase of overdoses during the COVID-19 pandemic and into the 2020 year. And since I am a numbers girl, I'll throw a couple numbers at you guys, so stick with me. And if you have any questions, please don't hesitate to ask. But to just show how much of that increase was, Indiana from 2019 to 2020 had a 13% increase in our ED visits due to overdose, a 36% increase in our overdose fatalities, and a 66% increase in our EMS naloxone administrations, which I think is the biggest one to show, especially as naloxone becomes more prevalent. And the state of how 2020 was there was a lot of, I don't want to say issues, but a lot of very hard conversations around naloxone at that time. So to still have that number increase by 66% is very surprising. And one point that I've always liked to share too is from 2019 to 2020, Indiana had 9 counties that increased their overdose fatalities by 50% or more. And one of those was Marion County, who is by population our largest and usually our leader in overdose fatalities. So to add to that, even after 2020 and 2021, Indiana actually saw their new peak of the drug overdose epidemic, reaching 2,800 deaths, which surpassed our previous peak by over 1,000, which is again why it was so alarming, that stark increase for us. And to jump back to the time period before, like I said, that first peak in 2017, we had surpassed it by 1,000, and we'd finally started to see that slight decline, which I know a few other states were, and everybody was kind of, rejoicing, thinking, oh, this is great, all the work we're doing. And then the pandemic hit and we just skyrocketed the other way. So yeah, it was a very high jump right after a lull. So very upsetting for a lot of people in this, but to wrap it up with some good news, Indiana actually has started to see a decline again from 21 to 22, and then through the first 2 quarters of 2023. So we're all very happy about that.
Yeah, absolutely. That is very promising and hopeful news. So I appreciate you sharing that after those pretty stark statistics. And, I'm going to pose kind of the same question to Sara, given your role in the state of Ohio. What are you seeing in terms of trends in overdose deaths? And are there any kind of similarities or differences in what you're seeing based on what Allie just reported from Indiana?
Yeah, definitely some similarities here in Ohio. So we also saw our highest year for unintentional overdose deaths was in 2021. So we had 5,174 fatalities that year. So happy to report that in 2022, we had a bit of a decrease. So we had a 5% decrease. So we're back under 5,000 deaths, which is heartening for us, but still 4,915 Ohioans died in 2022. So we did see a decrease, and then we also are happy to have that decrease. Overall, nationally, I believe there was a 1% increase on average. So that's something that we're happy that hopefully some of our efforts are starting to pay off in our state. And then we also have, since 2021, we've had Black non-Hispanic males have the highest rate of unintentional overdose death in our state. And so that is something that we've been watching since 2017. I'm not sure if I said 2021, but 2017 is when Black non-Hispanic males surpassed white non-Hispanic males. So we continue to watch that gap widen a little bit. And that's something that we're really trying to make sure that our prevention efforts are reflecting that change in demographics.
Yeah, thanks for that data, Sara. And I think, given the context of our keynote presentation from this morning, it's really important to talk about these health disparities that we're observing in our different states, certainly, and thinking about these different issues from that intersectional lens of, race and racism and health disparities and, health outcomes like overdose. So I definitely appreciate you bringing that forward. And I'm glad to hear that Ohio is tackling that as well. So this panel is about overdose prevention. And so we, I didn't want to spend too much time talking about the data, because I think that, over the past several years, this has been a topic of conversation across our states and injury prevention circles for sure. So I do want to spend quite a bit of time today focusing on overdose prevention and what folks in different states have done in that space. And so I'm going to turn to Connie and Amy. And I want to hear a little bit more about the work that you all are doing in Wisconsin as it relates to overdose fatality review, or OFR. OFR, as folks may know, is a data-driven strategy for overdose prevention. And so I would just ask that you just talk to us a little bit about your OFR work in Wisconsin. How many teams does the state have? And what is the coordinating structure for OFR overall in our state?
Sure. Thanks, Sarah. I'm going to kick us off, and Amy and I will kind of tag team this a little bit. But OFR has really been an evolution in Wisconsin. I've been involved actually since pretty close to the beginning, around 2016. And we started out with some pilot sites that grew into more pilot sites that grew into then regular teams that are part of, at least the funded teams that are part of our OFR effort within the state. So pretty much throughout that time, the way that things have been structured is the teams are co-funded, and our support is co-funded by the Wisconsin Department of Health Services and the Wisconsin Department of Justice. So through both CDC funding and Bureau of Justice Assistance funding, we've been really fortunate to be able to fund both our training and technical assistance support, as well as our local teams, through a combination of those funding sources. So we at the medical college, so Amy and I primarily, with some of our other team members, do provide the training and technical assistance, as Amy mentioned. So I'll talk a little bit about what that looks like. But since you asked about kind of how things are structured, one of the things I think is really important is that we do have what we call a state support team that is a combination of the Department of Justice, the Department of Health Services, and the medical college that meets on a very regular basis to help guide the direction of OFR activities within the local teams and across the state. To me, that's been really critical because it's brought in kind of that multidisciplinary perspective on what we're doing, as well as being able to work collaboratively on the direction and kind of the strategic mission of what we're trying to do with OFR. So that's been really critical. So I just wanted to make sure I highlighted that. So when you look at the TA that we provide, and I need to make sure I give Amy props because this is a significant part of Amy's role, and she's done a really great job of leading this effort over the last number of years. But essentially, we do everything from training the new teams, which has a whole process behind it now. That was an evolution in and of itself, where we do a multi-stage training process when we have a new team that's coming on board to make sure that we are orienting the leaders of that team and then orienting the team as a whole, working through a mock case review with them and making sure that we're giving them, documentation and tools to be able to hopefully get off on the right foot with their process. And then as part of that, we do follow up, and this is a lot of what Amy does with the teams, is making sure that they know they have a resource for just regular follow-up, but then also Amy does observe their meetings and provide them some feedback. And we try to continue to do that even with the established teams once a year, so that there's an opportunity to just make sure that we're touching base and that they have a resource that they can draw from in their actual carrying out of their review process. We also do things like we were involved in various parts of the setup and development of the OFR data system at the national level, but that's housed in Wisconsin at our state DHS, at our Department of Health Services in REDCap. And so we are involved in making sure that there's good documentation about that process, but then also getting new people to be trained and up to speed on using that data system for collecting information about their cases, as well as the recommendations that are coming out of their reviews. And there's quite a bit even that goes into just making sure that the DUAs get processed for that, so that everyone that needs access to the REDCap server can have access to it in a secure way. There's certainly a lot of ongoing process support. So Amy meets regularly with the teams to make sure that they have that kind of one-on-one touch point. And then we also do community of practice meetings. Most of those have ended up being virtual since COVID, but allowing us to really have the teams meet and interact with each other. We try to have a learning component as part of it, but we really have taken a lot of feedback from the teams along the way and trying to make sure that we are giving opportunity for them to interact. So we usually have some breakout rooms with some questions and ability for them to also share information about either successes or challenges that they're having along the way, so that they're learning from each other too and making those connections. Some of those modifications that we've made in that process, I think, have really been beneficial to the local teams in their work and their ability to work with others across the state. We also do have what we call the Overdose Fatality Review State Advisory Group. It took us a couple of years to get this established, but it's essentially a state level body that has representation from many of the key state agencies that have something to do with overdose prevention activities. So it's everything from DHS to DOJ to the Department of Corrections to our we have the Department of Children and Families, we have the State Lab of Hygiene, we have our overdose response strategy team, so a whole variety of different agencies and entities. But the purpose of that is we recognize that not all of the recommendations that the teams come up with can they implement locally. Sometimes they need that state level support. And so the intention is for this body to be a place where those state level recommendations can come to be presented. We can't guarantee that they'll always move forward to resolution, but at least that they're going to get the opportunity to share their priority recommendations with state agencies that are likely to be able to have some effect on what's happening with overdose efforts or substance use prevention or various efforts across the state. That process has really been an interesting and important piece of this, so that the teams know that there is support at the state level for what's happening, for what they're doing on a local level as well. We also do have, we try to do some version of an annual summit where we can have our local teams more involved in learning again with each other. That's really focused on OFR. And then, of course, there's just, Amy doesn't even begin to, she has so many questions that come in regularly from the teams that she just addresses and works through them. So knowing that they have that direct point of contact, I think, has been a really important part of our support. So just in terms of size, we currently have 21 county-based teams, and to give you perspective, that's 21 out of 72 counties. So we have a fairly good, in just 6 years, representation of the number of counties that are covered by OFR teams. We also have 4 additional local health department teams within the suburban communities in Milwaukee County, because we don't just have one health department in the county, we have multiple. And then I always like to highlight the fact that we actually have a team within our Division of Community Corrections within our Department of Corrections at the state level. That was really initiated by DOC, and still, I think, remains a pretty unique approach to OFR. In that it really generated out of their understanding of the risk and the number of overdoses that they were seeing for people that were on supervision with the Department of Corrections. And they've come up with, I think they hit recommendation 100 recently in the number of things that they have identified. And they've really moved a lot of things to action too, as have our local teams. So when we're talking about the number of teams that we have, those are our currently funded teams, and most of those are led by the local health departments. We had some variation early on in terms of who was the lead agency, but most of them are led by our local health departments. But it is important to note that if we have health departments, which we do in the state, that are interested in developing OFR but aren't necessarily currently funded under those 2 mechanisms that we talked about earlier, they can actually still look at entering into a data use agreement with DHS to be able to house their OFR data in the OFR data system. So we're still trying to make some of the resources available even to other teams. And Amy's been doing some regular meetings with those kind of interested in developing teams to make sure they're getting at least some level of support as they look at implementing OFR within their local communities. We also do, and part of our focus in kind of our new round of funding for the next couple of years is we're trying to think about ways to make the teams more sustainable over time. So we've already been providing some data like PDMP data for the cases that they're reviewing, but we're really working on expanding the data that they have access to for their, both at the aggregate level through our colleague at the Department of Justice who helps to support the OFR teams from a data perspective, as well as the Department of Health Services, but then also making sure that they have more opportunity to get case level data that can help to ease some of the burden and the time that's involved in preparing for case review. So they will be able to receive up to 5 years of EMS, hospital discharge, PDMP data, and then more recently, we've actually been able to start building in the Women, Infant, and Children program, or the WIC program, as well as the State Unintentional Overdose Death Reporting System, or SUDERS data, to help assist the local teams in their review process. So that's pretty exciting, and that's something we're going to continue to work on. We want to make sure that we help to build more capacity and sustainability. The funding levels have never been super high for the individual counties, but we also know that sustainability is going to be key to keeping these efforts going forward in the future. So as we have additional teams that are interested in implementing OFR, you know, we do try to support those, try to support them with the data as well. But also, you know, we spend a lot of time, and Amy spends a lot of time in particular, working with all of our local teams to make sure they have the support that they need for their case review process, and then with our colleagues at DOJ and DHS on the data support as well. So there's a couple other areas that as we go forward, we'll probably touch on today, but that hopefully gives you a bit of a sense of the structure, at least, of what's happening with OFR in Wisconsin.
Yeah, thanks so much, Connie. And I really appreciate the conversation around sustainability and, you know, the need to keep this this work going at the state level. And it sounds like there's a lot of really exciting activities happening around that in Wisconsin. So thank you so much for that. And Amy, I think this will probably come to you, but, you know, certainly one of the goals of OFR practice is to generate recommendations for prevention. And so in the local work that's been done in Wisconsin, what are some of the prevention recommendations that have emerged through OFR practice in Wisconsin? And have any of these recommendations been implemented that you might want to spotlight for us?
Absolutely. Thanks, Sarah. So yes, OFR teams make recommendations at both the local and state level, and even occasionally at the federal level, though there aren't quite as many good mechanisms for bringing those forward. But we do track all of those in the OFR data system that Connie's already referenced. So that OFR data system is a tool used by OFR teams across the country. Ours just happens to be housed in our Department of Health Services. So we have a couple different mechanisms for understanding what recommendations our teams are doing. So they are giving updates quarterly on what the teams are up to, but also they enter their local recommendations and state level recommendations into that system. And we have a report that we update each year that includes all the local recommendations. And so many examples of those recommendations fall into categories like K-12 education, prevention and community education, harm reduction, healthcare, first responders, criminal justice, support for families, treatment, and then data surrounding overdose. So broadly speaking, they fall into many of those categories. And there certainly are overlap of some of the recommendations from county to county. So part of the purpose of our community practice and other opportunities where we bring the teams together is to help them to be able to learn from one another and to share strategies for implementation. So, and then those recommendations at the state level, those can be elevated to the OFR state advisory group that Connie already referenced. And again, those recommendations are not always going to be implemented, but certainly there's more voice given to them than there would be by creating a report that is given to a governing body without discussion each year. So we really give that opportunity for the teams to share the great work that they're doing and to build the evidence base of why certain recommendations are needed for consideration in the state in order to help us all move towards prevention. So as far as examples of recommendations, we've had development of naloxone distribution programs at county jails. So that's happened lots of places around the state over the last few years, and it's been really great to see. Also, connection to peer support through county jails. So this is happening both at the rural and the urban level, and really has been helpful in building out that support for individuals who are particularly at risk after release from incarceration. We also have teams that have been working on coordination with motels and hotels for naloxone training. So this is something that's being explored, and again, sharing ideas between teams about what has worked and what approaches are not as effective certainly has been helpful. And then we've also had development overdose response teams. So we saw that we got a shout out from Sauk County in the chat a minute ago. Thanks for that from Sauk County. And that's a beautiful example of one where there's been development of an overdose response team. Essentially, when an individual would have a non-fatal overdose, that there would be a team usually consisting of some type of first responder and or law enforcement and peer support specialists. That's typically the model across the country. And that is an effort to, again, provide that one-on-one care to someone who might be in a place where they're receptive to referrals to treatment or receipt of harm reduction materials or education. So those have been particularly effective and great to see developing across the state. So lots and lots of recommendations. At the state level, there's many different categories they might fall into. Not uncommonly, there's recommendations for our prescription drug monitoring program of other activities that folks would like to see, as well as our Department of Corrections, and the OFR State Advisory Group is actually led at this time by Dr. Autumn Lacey, who is the in the Division of Community Corrections, and she helps to lead the OFR team that Connie spoke up internally at DOC as well. So there's really great merging together of those efforts, and gives a lot of opportunity for teams to share their ideas. So and then of course recommendations for our Department of Health Services and what folks would like to see as far as use of opioid settlement funds and grant efforts and programs surrounding things like harm reduction and increasing access to treatment. So really across a broad spectrum.
That's wonderful. Thanks, Amy. The recommendation around naloxone training at hotels, I think is such a great example of thinking, innovatively about places in the community where folks are, kind of meeting folks where they are, and engaging sectors in prevention that, may not otherwise be engaged in this work. And so it's a really great example of, I think, the innovative power of the work of OFR. So thank you.
Absolutely, thank you.
So I'm going to turn back to Sara and Allie for the next question, or set of questions, I guess. So, and I'll maybe ask Allie to go first, and then Sara. We've heard quite a bit in the news, at least here in Wisconsin, about synthetic opioids. And so I'm curious, first off, how have synthetic opioids affected overdose mortality rates in your state? And what strategies, if any, have you implemented either locally or as a state to tackle the issue of synthetic opioids? So Allie, I will start with you.
Yeah, thanks for this question. I think similar to other states, again, Indiana has had synthetic opioids as the primary driver of this wave of our overdose epidemic. In 2017, we started to see more increases, and then coincidentally, among the 2019 to 2020 year of COVID, we saw the highest jump of our synthetic opioids. And since then, we've been staying around 70% of our overdose deaths involving a synthetic opioid, namely fentanyl analogs, illicitly manufactured fentanyl. And to talk more about what we have done as a state, there's quite a few things, but I think the things of highlight, especially under our OD2A grant, would be we try to educate clinicians around the state about prescribing practices, co-prescribing naloxone with opioids, and the use of our PDMP system, which we call Inspect. Additionally, with that, we have tried to enhance our PDMP system to be more thorough, to catch more people, or to raise red flags. Or I know that sometimes there's issues with information not being updated as regularly or be as timely. So we've definitely tried to enhance that a lot. And then similar to what Amy said, we have a really extensive naloxone program and naloxone system throughout the state. In my team specifically, we have 2 grants that work with our LHDs and then our rural first responders who I think it's now up to 60 counties technically that work with our naloxone program coordinator to get naloxone into the hands of first responders, since it may not be as readily available at a pharmacy or at a hospital in those rural areas.
That's great. Thanks, Allie. Sara, how about you? The role of synthetic opioids and mortality in your state, and then strategies that you all have implemented.
Yeah, so fentanyl actually was first identified in Ohio in 2015 by our brilliant epi at the time, Babasi Carissa. So she's with the CDC now. But she was seeing it show up a lot in the literal fields of the death certificates. And so that's when CDC was on site. We had an EPA to try and wrap our arms around what was going on with fentanyl specifically. So the prevailing advice at the time was that we blanket the state with naloxone as much as possible. And I think over the years, we've gotten a lot more targeted with where we're placing naloxone, making sure that we're getting into high risk settings to reach people that are at higher risk. So we've become much more targeted with our naloxone over time. In 2017, that was our previous high for deaths, and it was largely due to carfentanil. I think we had over 100 carfentanil cases during that year. And so since then, in 2018, the percentage of drug involvement for fentanyl was hovering around 70%. And at this point, we're up to 81% of our fatalities have fentanyl involved. So we are very aware that it's completely adulterated the drug supply. And it is something that we've been working on for a long time. The first piece that was really important for us was around awareness. So we developed the OH Against OD campaign, and that has several different toolkits, both for Hispanic, Black, non-Hispanic, and rural populations, to really inform them in a way that is culturally appropriate for their either drug use habits or drugs of choice, about the fentanyl in Ohio's drug supply and the dangers that come along with that. So that was one of the first efforts that we launched. And then another one more recently is after several college kiddos got a hold of pure fentanyl they had purchased online that they thought was a different sort of drug and died. We've created a counterfeit pills campaign that we've launched to high school and college students. And so our integrated naloxone and harm reduction local, oh, thank you, Sierra. She's from my team. She just linked us up there. So our locals are really, like I said, working to make sure that we have naloxone and now fentanyl test strips available through, like I said, those settings where we can reach high-risk people. At the state level, some of the things that we've done recently are to really increase access to naloxone just for the lay public. So we've got all of the rest stops in Ohio are now outfitted with naloxone cabinets, and we've started to integrate fentanyl test strips into those. We've also offered naloxone cabinets to all of our colleges and universities. And so those are up and running. We've received several orders for those on college campuses, both to go along with that awareness campaign. And then fentanyl test strips have been a huge help. They were just legalized for use in April of this year. And so we've had a large push to get those out to our local partners. Sierra can probably put the exact number in there, but the last time I looked, we had almost 850,000 fentanyl test strips that have been ordered by our local partners. So really making sure that we're making that life-saving resource available. So those are more of some of our harm reduction efforts. We do have more just general drug overdose prevention efforts that we also undertake, but related to fentanyl, those are the key ones.
That's great. Thanks so much, Sara. It's really exciting to hear about, like I said, these innovative strategies. The strategy of having naloxone at rest stops throughout the state again is something that I think is really innovative and has the potential to be really impactful. Thanks for highlighting that. I'm throwing our panel a little bit of an audible here, and adding a question that I didn't have on our original script, but as you all are talking, I'm thinking about all of this work and how difficult it can be. And getting to these successes takes time. And so I'm curious, and I'll open this up to all four of you. Certainly feel free to jump in. What are some of the barriers that you've encountered in implementing some of these strategies, whether it's overdose fatality review or maybe community-based strategies, harm reduction strategies, and what has worked for you to help overcome some of those barriers or challenges? Feel free to jump in.
I'll kick us off, and I'll give my panelists time to think about a response as well. Although I may take one of theirs. I think stigma is probably one of the hugest barriers. So I will give the example relevant to OFR teams, but certainly others can jump in if they've experienced that as well in other statewide efforts. Certainly an overdose fatality review is looking for efforts to reduce overdoses and what are those prevention opportunities. But we use the socio-ecological model because we want to really emphasize to teams that you have an individual who's had an overdose, but that individual is surrounded by family and friends, and then they are part of a community that is also impacted by institutions and in larger policies. So we already had a comment from someone in the chat about a prosecutor talking to them about the legality of distributing harm reduction, right? So that is a great example of something along that model. And when we have potentially laws that are prohibiting something from happening that could be reducing the impact of overdose in the community, that is something that teams want to look at, as well as what's happening within our institutions in the community, right? What barriers are set up. So when we encounter stigma, it's oftentimes because there hasn't been a lot of good conversation yet, maybe in the county amongst partners that are bringing a lot of different perspectives about what the needs might be and what the evidence base is, or that would help support the reduction of overdose. So what we try to do is to make sure that stigma is addressed from the beginning, right? So when we do our initial OFR team trainings, we have a section on stigma and the use of person-first language. And oftentimes we encourage our teams to invite someone locally to present that section, right? Connie and I are certainly happy to do it, but it's usually more impactful to have somebody from the community, whether it's somebody that's working as a counselor or they're a peer support specialist or they have other experience and expertise to bring to the group. That usually is well received. That comes from someone locally. And then oftentimes teams need to think about what are their ground rules, right? What are they going to jointly agree upon for conducting the reviews that helps to think about all the things that happen across a person's life course, and then all those different layers as we think about that model that are impacting the person's risk for overdose. So continuing to have that conversation, continuing to bring partners to speak to the group and to share from their experiences, I think does help to reduce that stigma, but that's probably one of the biggest barriers that I would say our teams face, or a county might even face in their efforts to develop an overdose fatality review team.
And I'll just tag on really quick to that. I would completely agree with Amy that that is one of the biggest challenges. And so part of the training initially is to address things like person-first language and how are we talking about the individual and their social network and their family in a way that is respecting the individual and not tying them to their substance use or to their overdose. But even the resistance that we see to various harm reduction initiatives, to, there's layers, I think, to what we're talking about with stigma. And some of that, I think, is why the multidisciplinary team is so important. I don't think that we would have the movement and even the buy-in on some of the recommendations that Amy talked about earlier if it was not for having these broad multidisciplinary teams that are part of making the decisions about what they're recommending. That doesn't mean the teams don't run into barriers with things that, some folks on the team think should move forward and some on the team think should not. But it really seems to help that you get the multidisciplinary team exposed to the lives of individuals and the situations that are involved. And then part of what a lot of teams are working to do as well is have people with lived experience actually part of the team. And sometimes that's overtly, sometimes it's that we know we have multiple people that are on the team that may or may not acknowledge that they have lived experience. But having the perspective is hugely important. And I think it's an area that a lot of both certainly OFR teams, but also just folks that are working locally on overdose prevention are trying to make sure that the voices of those who are closest to the issue. They often have the best perspective on what are things that we can think about in terms of prevention. So those are, just to tag on a bit to Amy, some of the things that are both challenges, but also I think opportunities that local communities can consider.
Great. Thank you both. Allie, I saw you unmute. Go ahead.
I'll kind of piggyback off of the end of that and say I agree with stigma being one of the biggest barriers, and I'll plug one of our agencies in Indiana, Family and Social Services Division of Mental Health and Addiction, have a campaign called Know the Facts that they focus on busting the myths around substance use disorder. They lay out the language and how you should speak to people when you're talking about this, and how you should talk about the entirety of the substance use disorder world. And I know that a lot of our sister agencies in Indiana, we all use it because it is such a great resource. They have it on their website, and they have pamphlets, brochures, PowerPoints, and they have it in multiple different languages, which makes it great for serving all of the populations that we have in Indiana. So if anybody is looking for any resources to use or to copy, please go check out Know the Facts. And then I'll put in here too another one, another barrier that I'll say from a data perspective is the overdose and the substance use disorder world is so broad, and it has so many nuances, especially when it comes to our data, that since I've been in this role, I've experienced that a lot of people don't understand those nuances and will choose one data point to latch on, even though there's 4, 5, or 6 that you could use to prove your point or to help you or to use in any of your programmatic areas, and trying to explain to people, hey, there may be a better source, or this may be better for what you're talking about, and understanding what those sources are. For example, we have a couple of sources that are suspected overdoses that people like to use a lot more than are confirmed, and we have to help them understand, okay, well, one is, what we suspect we may not know is true, well, the other one is, it's hard fact, it's the data for sure. And getting them to understand the differences of, well, why does it look like that, and why does it change between the two? So I think that's a really big one, is the lack of understanding. And I know our team has worked really hard, especially under our Health First Indiana, which is a new initiative throughout the state, to work with local health departments and get them the relevant data for them and help them understand how they can use it for any of their program areas.
Great. Thanks, Allie.
So my turn again would echo stigma. I would also just add that even when we have people with lived and living experience on our coalition, and even when you are as sensitive as you can be in using person first language, there are some long-term historical issues that people have had. We've got medical personnel, we've got law enforcement, we've got all sorts of professionals on our coalition. And so it's not easy to have those conversations. And so the way that we've been able to overcome it is to make sure that we're staying open to those conversations, making sure that everybody's different viewpoints are respected and heard when we're having these conversations. So even when you use as much person first language as you can, there are still just some longer term issues that people have experienced that are difficult to overcome.
Yeah, absolutely. Yeah, thank you for all those responses. And I really appreciate the focus on the inclusion of folks with lived and living experience in this work. And we talked a bit about, the integration of certified peer specialists into this work, as well as, another example of that inclusion of lived and living experience in this work. So I certainly appreciate you all mentioning that. And working, in the suicide prevention space myself, I know how powerful stigma can be and how challenging and difficult it can be to overcome. And so just appreciate the strategies that you all have shared related to that. And so this is the final question, and this is one for all of you as well. And then we will open it up to our participants here to see if there are any questions. I see some in the chat that we'll start with. But my final question is, what do you see as the future of overdose prevention, whether that's maybe an innovative prevention strategy or improved surveillance? How do you see that future unfolding for us? Should I call on somebody? Allie, go for it. I saw you on mute.
Go for it, Allie. I'll go next.
I mean, I don't want to keep repeating what everyone said, but everybody has had such great examples of the work that we do. And I think taking all of the strategies we have, like harm reduction and syringe service programs, overdose fatality review teams, and continuing to improve upon those is something that I can't say would be valuable enough for our world, instead of trying to reinvent the wheel with new ones and changing things. But I'll also sprinkle in again. I'm sorry for all the data points. This is my life daily. But one of the things that I know that a lot of people have started to do, and that Indiana is starting to do, is do innovative surveillance and data linkage of multiple sources. And the one that we are doing is taking anyone that's had a fatal overdose and linking touch points throughout their life to see where we can intervene and how to educate the people that they are intervening with, such as the Indiana State Police or our Department of Corrections. And I think that is a really useful tool, because it not only shows you where someone is throughout their lifespan, but also where we can continue to create partnerships to make room for conversations and improve upon the overdose surveillance world.
Very exciting.
I would echo the importance of that, using innovative approaches to working with data, linking data, but also just making data more available to partners. So we helped to establish a dashboard in Milwaukee County. There's a lot happening at our state Department of Health Services around trying to make more near real-time data available, so that we have a better handle on what's going on. But that can be available to a variety of partners that are working in overdose prevention, but also thinking innovatively about how to have two-way data flow. So there's been a lot of discussion about utilizing apps to have individuals be able to provide information about what they know is happening within the community in a confidential and often anonymous and secure way. And so really thinking differently about how we can use data. One of the other things that's happening, at least in Milwaukee County, is also thinking some of our partners at the health department and the ME's office and our overdose response strategy team, kind of building off of some of what has come out of this work, is doing some innovative testing of substances within the community as well. And whether that be substances that are seized by law enforcement, or drug checking that is related to syringe sites, or even things that are happening at fatal overdose scenes. So some of the other ways of looking at how can we understand what's in the drug supply and how can that then inform prevention and intervention efforts, I think are some of the other innovative ways. I know Amy's got a few more of those, so I'll pass to her as well.
I'll let Sarah go. She tried to unmute a couple times, so I'll follow up you, Sarah. Go ahead.
Thank you. Not innovative, but I think we need to scale all of the work that we're currently doing. So that's really important, to be able to saturate our states and our region with this life-saving work. The other piece that I think is really innovative and much needed is if we can evolve past the stigma. I feel like drug overdose is where HIV was 40 years ago. If we can get past the stigma and really get into a case management model for people who have overdosed, identifying people with an issue early and being able to get them the services they need and meet them where they are. For me, that case management model moving forward is really the ideal. But like I said, we have a long way to go before we can get to that.
Absolutely. Amy.
Thanks. I concur with all that my fellow panelists have offered. And I also would say that OFR has really helped to me to emphasize the intersectionality of everyone's life, right? And all the different factors that can place a person at risk. And some of them are really downstream, right? Making sure that folks have harm reduction, that they're not using alone, all of those pieces that will help prevent an immediate overdose. But as we dig into our case review, we always are appreciating the role of trauma in a person's life. And so I think if we want to see overdose really go down and other deaths of despair, right? So loss from suicide as well, that early intervention when people have experienced trauma and the connection to health outcomes that are really detrimental. So I feel like that's the direction that we need to all head. There's not an easy answer to how to do that, but that's something that we really want to emphasize. The other piece would be, we have lots of data that's broadly available now. It sounds like in all 3 of our states and in other states as well. And Sarah, you touched on this earlier, but how do we examine that data and then help it really inform what individuals may need that are within certain groups or populations in the community? So for example, in Milwaukee County, we use the data to help us drive what themes we're exploring in the case review we're doing. And we've seen that there are some definite differences in the age distribution by race and Hispanic ethnicity demographic groups. So how do you think about your messaging and your prevention and reaching different groups when the impact might be on older individuals who are African American, for example, in Milwaukee County, compared to younger individuals who identify as white? So how do we think about how we tailor our prevention efforts to make sure that we're meeting, again, those intersectional needs, where we're not looking just at race and ethnicity, but also race and ethnicity and age and sex and where individuals might be located in the community. So hoping to see us all continue to improve that.
Wonderful. Thanks so much to you all. Really appreciate your stories and the discussion today in this panel. It's been really helpful, really informative, and exciting, frankly, to hear about all of the work that's going on to help prevent this issue in our communities and our states. So I'm going to go to the chat and open up the last 9 minutes or so for questions. I do see one specific question from Leah. Hey, Leah from Wisconsin. I think going back to Amy's discussion about recommendations, where can we find those reports with the prevention recommendation categories? And I'm wondering, Amy, if that's something that folks in other states could look to as well as a resource.
Yeah, thanks everybody. So right now, Leah, thanks for that question. That report has been used internally so that other OFR teams know what their fellow colleagues are doing, right? And so the report that we have lists their recommendations that are at various stages of implementation and consideration. So they're not necessarily ready for public facing at this point, but they are to help each other work together across counties. And then we also help to tie in the evidence base, right? Help them identify articles or resources that might help them consider the implementation of those recommendations. But what I can point to is that a number of our counties have begun to do annual reports from their OFR teams. So this is something that can be available on county to county, but we really like to put the ownership of those local recommendations with that local team. And when they're sharing those, it's typically within their annual reports. Our OFR State Advisory Group is a public meeting, so that's held quarterly, and there is discussion of recommendations within that meeting as well. Folks are certainly always welcome to join. And Leah, being a fellow Wisconsinite, certainly reach out to me if there's anything you'd like to connect with specific for any counties in Wisconsin.
Thanks, Amy. So I do see there was some discussion in the chat. Lori began it. We were told by our local prosecutor during one of our fatality review meetings that it is a crime to have those test strips and distribute those as well. Looks like there was some back and forth, including an article from the CDC, and then why they are illegal in some states. I don't know if our panel has any thoughts that they want to share on that discussion.
I think I would just say it's important to know what the law is in your state. We spent a good period of time in this kind of waiting in Wisconsin until the law was changed, at least for fentanyl test strips. Now we're in the conversation about, well, what about other test strips that aren't specifically outlined in the current statute? So they were not legal in Wisconsin for a pretty good period of time. They are legal now for fentanyl test strips in particular. So I definitely would just encourage you to look at what is going on locally. And this is, can be a state level recommendation to look at potential statute changes, because they are often supported by federal funding even, but if at the state level they're not supported by state statute, then you're in a tough position to be able to utilize that as a resource.
Yeah, and it looks like Pam just asked, can one of the panelists share the language of the statute in Wisconsin?
I can look it up and I'll paste it to you, Sarah, but I can't, I don't think I can post to the whole group. So.
I will do that then. So stay tuned. We will have that in the chat for you all. I am just scrolling through the chat here, noticing that folks are also sharing some really great resources related to the Inspect program, which I believe was mentioned by Allie in Indiana, Ohio Against Overdoses, Naloxone Ohio. So just encourage folks to check out those resources in the chat if those are helpful to you. I'm just going to give it a second and see if there are any additional questions from our participants in the audience. Bianca just asked a question. Is there a campaign to change the laws at the federal level to override state laws? Is anybody aware of any advocacy on the national level in that space? I'm seeing no's, so it doesn't sound like that is something that is, unless others are aware of something, it seems like that's not something that is currently available. Okay. Well, certainly if you do have additional questions for our panel, we can help make those connections for you. I would really like to thank our panelists again for their work in their states, as well as their willingness to share their expertise with us today. So really appreciate you, Connie, Amy, Allie, and Sarah. Thank you so much. I do have just a couple of announcements before we break for lunch. At this time, we'll be breaking for lunch for 45 minutes. Again, before we do, I just want to encourage you all to grab your own lunch and take advantage of this time to connect with and network with colleagues from across the region. And you can do this either by connecting with people one-on-one for chats or using the networking match tool on the website. We also have, again, as I mentioned earlier, we have highlights and update reports for each state or from each of the states for our region. And I encourage you to review those reports in the digital conference folder, either now or at any time after the conference. And then after lunch, there will be 2 breakout sessions with 2 options for breakouts each. You can preview these sessions in advance and you will be able to access the sessions at the start time. And there will also be a break in between the sessions to allow you to stretch and network and make it to your next session in plenty of time. And then after those breakout sessions, we will hope that you please join us back on the main stage for our closing keynote with Dr. Lois Lee, and then some closing remarks as well from Morgan and myself. So I encourage you all to enjoy lunch. Again, that networking option's available. We will break for lunch until 12:15 Central, 1:15 Eastern, and then you can find us back starting at that time. So thanks so much, everyone, and have a great lunch. Appreciate you.
And the statute's in the chat for you, Sarah, if you want to post it in real quick.
Thank you so much. I will do that right now. For folks that were interested in that, thank you, Connie, putting it in the chat. There you go. So thanks so much, everybody, and we will see you after lunch. Take care.
For the opportunity.
Thanks, everyone.
Thank you.
Bye-bye.